Good day, everyone, and welcome to the Evolut System Organization of the Low Risk Young Patient Symposium during TCTAP 2022. This is going to be hopefully a very interesting session with wonderful presenters and a great panel. My co-moderator, Dr. Chair, will join me later. So without further ado, I think we can start with Dr. Ko from Severance Hospital in Korea. What we need to know about coronary reaccess after TAVR. Dr. Ko, welcome. The floor is yours. Great to see you again.
Thank you very much for the introduction. It's my great pleasure to have the opportunity to present the prevalence of coronary artery disease among patients undergoing TAVI, especially in intermediate and high-risk patients, is reported to be over 50%. The CAD prevalence among lower and younger patients is a little bit lower. However, as these patients get older, they may catch up with coronary artery disease events, and they are expected to have more instances of PCI after TAVR. According to the US Medicare data, approximately 5% of the patients treated with TAVR undergo PCI after median time of 300 days. The most frequent presentation is the NSTEMI. In another retrospective study, about 1% of TAVR patients required PCI at median duration of 190 days after TAVR. In this study, PCI success rate was 96.6%, so very high. This is also a retrospective study of patients undergoing diagnostic coronary angiogram or PCI after TAVR. In this study, diagnostic angiography was successful in over 98%. In patients requiring PCI, guiding catheter engagement was successful in 97.7%. So almost in all cases, the guiding catheter engagement was successful. In patients requiring PCI, guiding catheter, only 6 cases out of the 21 PCI cases failed due to coronary artery access issue. Among them, only 1 case was Evolut valve case. In most of the cases, diagnostic angiogram was successful with Judkin catheters. Unselective catheter engagement and use of more than 2 catheters was more common with long stent frame valves such as Evolut valves. This slide shows the predictors of unsuccessful coronary artery cannulation after TAVR. The small space between sinus of Valsalva and TAVR valve and high valve implantation in relation to coronary artery ostia were associated with the difficulty in coronary artery cannulation. However, self-expanding valve with high frame was the most important predictor of the failed coronary artery selection. Thus, if a patient undergoes TAVR has a coronary artery disease, we may consider first lower frame valves with easier coronary access. However, no valve is perfect. Evolut valves are thought to be advantageous in cases with relatively small lumen vascular access, severe or unfavorable calcification of aortic valve, and in patients with the risk of coronary obstruction, and patients with small annulus. And if we need to annulus sizing using echo due to the decreased renal function, or in emergency cases, or in patients with severe LV dysfunction, we may prefer Evolut system over balloon expand or valves. So in such cases, we have to get a strategy to cannulate coronary artery system for the successful PCI. So this is a case of the coronary artery obstruction after TAVR. According to a study, balloon expander valve has a higher risk of coronary obstruction, and the self-expanding valve, such as Evolut valve, has an advantage because of the frame design with waist in the middle and also slow expansion, valve expansion mechanism. I'd like to show a case. This patient had calcified SEC leaflet, and SOV diameter was about 30 millimeter, and the left coronary artery ostium height was 11.5 millimeter. In this case, we initially planned to use sapien valve. However, after watching the aortogram taken during predilation, we changed our mind and chose core valve. As you can see here, there was a shift of calcified leaflets towards the left main ostium. And so in this case, we implanted core valve. It was very a long time ago. And so after the valve implantation, the coronary flow was maintained. So we did not perform coronary stenting in this case. However, after TAVR, the patient complained of chest discomfort. So we did CT scan and found severe stenosis at the left main. This was caused by the shifted calcified leaflet. So we decided to perform coronary angiogram, and fortunately, in this case, we managed to position the guiding catheter at the frame cell near the left coronary ostium, and we were able to pass the wire to the LAD, and we had no difficulty to perform PCI with coronary stenting. This slide shows CT scan images and angiograms before and after coronary stenting. But it is not only the frame height, but the valve commissural post. They can also make the coronary cannulation difficult if it faces the coronary artery ostium after valve implantation. As you can see on this slide, the skirt height between commissural posts is about 13 to 14 millimeter, depending on the valve size. But the commissural height is 26 millimeter at the commissural post. So it is high enough to cover coronary arteries in most of cases. This case shows the commissural post facing the LCA, left coronary artery ostium. This may be the worst scenario for coronary artery access. Therefore, in order to obtain easier coronary artery access after TAVR using Evolut valves, we need to be able to control the orientation of commissural post during TAVR. However, before the final release of the Evolut valve, the direction of the commissural post is difficult to know. Thus, some investigators found that the head marker on the delivery catheter may help to guide the direction of the commissural post. The CTAP, one of the commissural posts attached to the delivery catheter, is loaded 90-degree clockwise from the head marker. When we insert delivery catheter with the head marker directed to the outer aortic curve, which occurs in the most of cases, then the CTAP orientation is directed to the inner curve. So conversely, if the head marker is directed to the inner curve, then the CTAP will be directed towards the outer curve. If the head marker is directed to the inner curve, the chance of the overlap of the commissure with the left main is 66%. And the overlap of the commissure post with the ICA is over 50%. Whereas the overlap of the commissure with the left main is only 15%. when the head marker is directed to the outer curve or center front. Therefore, it is important to introduce the delivery catheter with the flash port directed to 3 o'clock. With that maneuver, we can control the head marker orientation to the outer aortic curve. With this method, we can achieve almost in 90% that the head marker faces towards the outer curve. This is the modified the delivery maneuver, and this is the conventional method with the flush port faced up to the upwards. So I'd like to show our case. We introduced the delivery catheter. So with the flush port facing to 3 o'clock, and then we check the direction of the head marker. And then as we advance the delivery catheter, we try to keep the position of the head marker directed to the outer wall. Okay, so the head marker is directed to the greater curve of the aortic arch. And then we deploy the valve. After final release, as you can see, the CTAP is directed to the inner curve. So next, I'd like to talk about some tips for PCI in patients treated with TAVR using Evolut valves. I have to confess that I have myself limited experience of PCI after TAVR. So maybe as a first attempt, first method, I think picture aortogram may be helpful to find the cell next to coronary artery ostium. Keep in mind that the top of the ceiling skirt between the commissural posts is about 2.5 cell diamonds, and 5 diamonds is the top of the commissural point. In most of cases, 3.5 or 4 jockeying catheters will be sufficient for engaging the coronary artery. Try to target the valve frame cell that is coaxial to coronary ostia, and always take the catheter tip into the frame cell over the guide wire. If there is difficulty with the frame cell that is directly coaxial to the ostium, use the frame cell to the left or right or above the ostium. So cannulation of the ostium from below the coronary takeoff is not recommended because of the supraannular design of the valve. So for instance, EBU or XB guiding catheters may not work in these cases. So if coronary engagement is not successful, we can try following steps. We can change the guiding catheter size, and we can try the partial selection and then try to pass the wire into the coronary artery system. And if that succeeds, then we can use additional guiding extension. And then we can perform stenting over the additional guiding extension. And after the stenting, do not pull the guiding catheter without having the wire in the coronary artery system. With that method, you can you will not catch the valve frame, and then we may avoid the problems. And this is the additional tips. You may reach the lowest cells with using J-wire. And as I already told you that we can try with the wire to select the coronary artery system if the guiding catheter did not go into the coronary artery ostium. And then using guiding extension is also very helpful. We had the chance to use a hot rod simulator to see how we can engage the coronary artery ostium with guiding catheters. This is the machine, and the hot pumps, and then we can try to engage the coronary arteries with this machine. And we used the Judkin catheter, and then we check the coronary artery with the contrast dye, and then we can select the coronary artery without a problem, as you can see on this slide. So this was not that difficult. And we after engaging the engagement of the left coronary artery with Judkin 3.0 was not difficult, and it was also feasible with the Judkin left 3.5 guiding catheter. The valve was 29 millimeter valve, and we also tried with the AR2 guiding catheter, and direct engagement was not possible. But in this case, it was not difficult to bring the wire into the coronary artery system after several attempts. And with that method, we can also deliver the coronary stents and then perform stenting. For the right coronary artery engagement, Judkin 3.5 was also successful, and it was not difficult to engage the right coronary artery system through the valve frame. And we also tried with the AR2 guiding catheter, and we succeeded to engage the right coronary artery ostium with this method. And also passage of the wire was not difficult, and indirect cannulation, and delivering the coronary stent was also successful. So these are my take-home messages. Incidence of PCI after TAVR is expected to increase as the indication of TAVR expands to younger and lower risk patients. In general, the success rate of PCI in patients treated with TAVR is over 90%. Indirect selection of coronary arteries for PCI is still feasible in most of cases, even though the direct coronary artery cannulation with guiding catheter might be sometimes difficult in case of Evolut valves due to the high valve frame. The orientation of commissural post away from coronary artery ostia by positioning the head marker towards the aorta arch outer wall is of great importance to secure the coronary artery access for future PCI. Thank you for your attention.
Thank you very much, Dr. Ko. Excellent overview of how to deal with coronary access after TAVR. I think if I'm reading this right, we're going to have a discussion afterwards. So I see my co-moderator, Dr. Che, joined. Welcome, Dr. Che. I will introduce the next speaker, who doesn't need any introduction, our good friend Didier Che from Toulouse. Didier, welcome. And you will teach us about the bicuspid aortic stenosis or bicuspid aortic valve. Welcome, and the floor is yours.
So, my dear friends, it's a real pleasure to drive you through this the next 15 minutes towards the sizing and treatment of low-risk bicuspid patients with the Evolut platform. So here are my disclosure. So the first thing that we have to understand is that bicuspid, when we talk about bicuspid patients, most of the time these are selected, very selected patients. And in this group of selected bicuspid patients, when we focus on the low-risk population, we have had that Evolut low-risk bicuspid study that demonstrated that treating bicuspid patients, mainly type 0 and type 1 with the self-expanding Evolut Pro platform, provides excellent outcomes with a high device success rate, low mortality and stroke rates, and most importantly, exceptional hemodynamics with very large EOAs, more than 2.3 centimeters square, and a single-digit mean gradient. And this is correlated to a very low severe patient prosthesis mismatch occurrence. So it works in selected patients. When we compare that to surgery, comparing the data in this meta-analysis of low-risk tricuspid patients who underwent TAVI compared to bicuspid low-risk patients who also underwent TAVI, it's clear that there is a kind of similarity of the outcomes, with the caveat of a potentially higher risk of stroke rate in bicuspid patients. We may discuss that afterwards because it has some implications in terms of procedural steps. But definitely we have positive signals towards the safety and the efficiency of treating bicuspid patients, particularly with the Evolut platform in the low risk population with contemporary sizing and contemporary techniques. But let's keep in mind that these are still selected patients, and we also know that if the patient combines a severe calcification pattern and the presence of a raphe, particularly if the raphe is really a lengthy one and a calcified one, that combination is going to increase the mortality of the patients at 2 years, up to 2 years after the procedure. So TAVI in bicuspid patients, when we treat extremely calcified and raphe type patients, may not have such good outcomes as compared to more favorable anatomies. So the selection of the patients makes sense. When we are talking about low risk patients, we may face younger patients, and this bicuspid may also be associated, apart from the calcification pattern, with dilation of the ascending aorta. And this also could be one indication for redirecting the patients towards surgery, apart from the coronary lesion issue or associated over valvular diseases. But these are the main patterns: calcification and dilation and ascending aorta aneurysm, that could be reasons for not offering TAVI to our patients. So having said that, as we know that in selected low-risk bicuspid patients, we may have a very excellent clinical outcomes, but also excellent hemodynamics. These has something to do with the sizing. So we have learned all across the past 10 years how to size our patients, to get a nice ceiling, low gradients, and a nice expansion of the stent frame. So we all know now that the CT, MSCT is the gold standard for sizing for bicuspid aortic valves, particularly that CT scroll technique. And it means that you're going to first, you need to acquire a high quality CT scan. Second, you scroll from the LVOT, then the annulus, and then the supraannular region to better understand what is the phenotype, the bicuspid phenotype that you are dealing with, what is the lifted distribution, what is the calcification pattern. We have discussed that before. And if there is a raphe, and if that raphe is calcified. So we size the annulus, and we also do that kind of supraannular sizing, whether it be a tracing, supraannular tracing 4 to 8 millimeters above the annulus, or the commissure to commissure distance. And this is all about understanding what is the configuration of the landing zone. So that CT scroll technique is the reference. It has to be mastered, because this is really key in selecting the proper device, the proper valve size, and to make sure that we're going to get outcomes as good as the ones that have been provided through the literature, because the patient are selected first, but nicely, perfectly sized with that CT scroll technique. When we do that combination, that a correlation between the annular dimension, as we are dealing with a self-expanding platform, the perimeter-derived diameter of the annulus, and the supraannular sizing. In that Bavard registry, the supraannular method that was utilized was the commissure to commissure distance 4 millimeters above the annulus. Some may do the supraannular tracing, but when you combine these two measurements, you get a kind of understanding of the landing zone configuration. If the annulus matches the dimension of the supraannular commissure to commissure distance, more or less 10%, you size based on the annulus, it's going to work. If you have that flared configuration, because we start from the annulus as the starting point of the landing zone, and then the supraannular region, and if the commissure to commissure distance is more than 10% greater than the mean perimeter derived diameter of the annulus, you get that flared configuration. You're going to size based on the minimal dimension that is still the annulus. It's only in what we think is the most common phenotype for a configuration of the landing zone for bicuspid, this tapered configuration in which the supraannular measurements are more than 10% smaller than the mean perimeter derived diameter of the annulus. We're going to size based on the supraannular dimension. But when we analyze the overall cohort in the Bavard registry, in close to 90% of the cases, we have a tubular or a flat configuration, meaning that we can size in 90% of the cases based on the annulus. So this is quite reassuring. In terms of metrics, to make it simple, if we focus on the Evolut platform, if you size based on the annular dimension, it's going to be a kind of 50% oversizing ratio. If you decide to size based on the commissural to commissural distance in this tapered configuration, it's close to be a 1-to-1 ratio, just to provide you with a kind of a rough assessment of the oversizing ratio needed for your patient. I don't personally believe in the balloon angiography to size for bicuspid. I don't think that it's relevant apart from seeing the movement of the calcium. If you decide to use a balloon expandable platform, instead of the balloon sizing, I strongly recommend to use the circle method, putting a 23, 26, 29 circle within the anatomy of the patient and trying to understand what is going to be the relationship of that stent frame with the surrounding structure. Is there a risk of sequestration of the sinuses, higher risk of coronary obstruction, damaging the annulus? So the circle method makes sense. I don't believe in the balloon sizing. We might discuss that afterwards. So this is something that is still work in progress. What we found here in Toulouse is that when you do the supraannular tracing and you take the mean perimeter derived diameter 4 millimeters above the annulus, whatever type of bicuspid that you have, this is going to provide you with an estimation of the final mean perimeter diameter of the stent frame of the device that you're going to use, particularly a self-expanding platform, after the procedure. So this may prevent you from oversizing too much the device according to your patient anatomy. We can put big and big and big. It's not going to reach the maximum diameter, and there is a risk of unfolding of the stent frame, higher risk potentially of leaflet thrombosis. So selecting the proper valve size makes sense. If you are in doubt, you can do that supraannular tracing just to anticipate the mean perimeter derived diameter of the stent frame. So just to keep it simple for the sizing, CT is the gold standard. Annulus works in 90% of the cases. Supraannular sizing to understand the landing configuration of the landing zone. Circle method for balloon expandable platforms. We have to be cautious when it's tapered and calcified and avoid excessive oversize. So in the last remaining 5 minutes, I'd like to drive you through some procedural considerations. The first one is the projection, the working projection that we're going to use. We are now used to, even for tricuspid patients, to move to that cusp overlap projection. And it's exactly the same principle, the same spirit for bicuspid patients. We have 2 leaflets. So the idea is to isolate the unique leaflet and then the combined ones in 2 different locations of the screen. And most of the time, as type 1 left to right is the most frequent phenotype, working in the areocaudal projection makes sense. So you have to work with your CT scan just to understand how you can get that 2 cusp view, putting together the fused cusp and in opposition, in the opposite aspect of the screen, the leaflet that is not fused. So that view is very important to obtain before the procedure. We are always aiming at high implants. This makes sense. This is contemporary, whatever device we utilize, aiming high, but we still have to remain across the aortic annulus. In terms of more advanced procedural details, if we only focus on the Evolut X data, what we can see is that with the self-expanding Evolut Pro Plus platform, a lot of pre-dilatation, close to 90% of the cases, repositioning very often, post-dilatation, just to take advantage of the features of the device and the ability to expand furthermore the stent frame with the post-dilatation. And this is going to correlate with nice outcomes, exactly in the same as the low-risk bicuspid, large EOAs and low gradients. Something that is also contemporary, and we've seen that with the previous talk, commissural alignment has to be part of a contemporary procedure, and it's the same for bicuspid. If we have a type 1 left to right, that is the most common phenotype of bicuspid, we still are trying to align the CTAP with the RAFE. It's more or less the same thing as for tricuspid patient. Cusp overlap projection, areocaudal, and the flush port 90 degrees as compared to baseline. Flush port at 3 o'clock, and this is going to work for a type 1 left-right bicuspid. The most difficult scenarios is when you are facing a non-type 1 left-right bicuspid. as for example, this type 0 bicuspid, and you can clearly understand that the orientation of the osteums of the coronary arteries is way different as compared to tricuspid patient, and this has been the subject of a very recent publication nicely showing that. So we need to work a bit more just to avoid the risk of coronary and commissural post misalignment, because this is more frequent in non-type 1 left-right bicuspid. This is another example of a patient with a type 1 right non-bicuspid, and we had to work a bit just to get a proper commissural alignment. And you know now, because it was also explained through the first talk, how to rotate the catheter to get a proper commissural alignment in tricuspid patients. Here, if you have a close look at the left loop, you can see that the marker, the heart marker is more located now in the inner curvature of the aorta in this LAO projection, meaning that we had to rotate at the flashpot at 8 to 9 o'clock just to try to match in a proper way the commissural alignment for this type 1 non-right bicuspid patient. And if you watch on the right loop, you can see that the CTAP is in the outer curvature of the aorta in this LAO projection, which is more or less the opposite of what we are advocating for tricuspid patients. So we need to work to get a proper commissural alignment. So let me conclude and trying to remain on time. So we have seen what are the key messages for sizing in bicuspid aortic valves. Technically wise, remember that you need to work to get a proper two-cusp view, pre-dilate, usually using the minor diameter of the annulus at baseline, and this is really important for self-expanding platforms. Work to get a proper commissural alignment according to the phenotype, the bicuspid phenotype that you are dealing with. We need to get high implants, but high implants doesn't mean above the annulus. All the clinical results that were good were in patients that were treated with a device that gets across the aortic annulus, and we need to reposition if necessary with the self-expanding platforms. The stent frame has to be assessed in two orthogonal views to decide whether or not to post-dilate, because frame optimization is part of a contemporary treatment of bicuspid patients. So thank you very much for your attention.
Thank you very much, Didier. Excellent, very educational presentation of bicuspid, obviously a lot of personal experience. Thank you for sharing this with us in this session. Dr. Chair, you want to introduce the next speaker? I think it's a pre-recorded lecture, if I'm not mistaken.
Yes, so thank you very much, and I'm happy to see you all. So the last lecture is PPI, about the PPI. This lecture will be done by Byung-hee Hwang, and he is working for Catholic University, Seoul St. Mary Hospital. So please play the recorded lecture.
Thank you, Chairman. My today's topic is in lower risk younger patient crossover technique. So in the COVID-19 era, same-day TAVR and unanimous approach in TAVR is being a very important issue. In 2020, ACC guidelines have been changed, so recommendation for even in 65 to 80 years old, either surgery or TAVI can be done after shared decision making about the balance between the patient longevity and valve durability. So for the extension of TAVR into low risk or younger patients, we have to solve the permanent pacemaker issue, subclinical leaflet thrombosis issue, and the durability issue. Today we're going to talk about the pacemaker issue. Low risk TAVR registry, new permanent pacemaker implantation was 4.8%. The type of the valve was both. In K-TAVI first cohort, you can see the PPM implantation rate was 5.6% in about 500 patients. In partnership trial, PPM after TAVR in 1 year was 7.3%. And in Evolut low risk trial, you can see after 1 year, about 19.4% has been PPM implanted. So how to avoid new PPM implantation? We have to identify the risk factors of post-op or high-risk deviation block. There are clinical issues and anatomic issues and post-operative related issues. We're today talking about anatomic and post-operative related issues. So there are variations in location of the left bundle point, and septum thickness and thickness of non-chronic acid, and large amount of calcium. We have to think about the radial force of the prosthetics and the implant depth and the balloon autovalvuloplasty and the learning curve. So cuss overlap technique can be surprisingly reduce the PPM rate. You see the cuss overlap view isolates the NCC by overlapping the RCC and HCC and generally in the RAO imaging plane. This view provides a good anatomical reference for the deformity depth point of contact NCC, and it maintains the base of the plane alignment of the coronary cusp. It elongates the outflow tract in a long axis view. As you can see in this conduction system and the LTFL, we need an even view to make LVOT on the NCC as long as possible. You can see the NCC can push this LV left branch and near the IV node. So cuss overlap technique shows a greater visual separation between the basal-annular plane and the conduction system in the cuss overlap view. You can see cuss overlap view, you can see the visual separation. 3 cuss coplanar view, very close to the conduction system. Visualize surprising in this cuss overlap view. So the cuss overlap technique starts the implantation in the cuss overlap view and starts higher, then slowly deploy and make the valve slowly descend into the annulus, and slowly valve release until the control pace point, control pacing to the point of no recapture. And then confirm the depths, and after checking the echo for performance, then release slowly and methodically. So in the Latin American early adoption of COT, this PPM rate was reduced to 5.7%. I'll show you 80 male with CVRFs. So after pre-ballooning, we started cuss overlap view just above the annulus. Slow implantation, and make the valve automatically get into above the annulus into the LV slowly. And then check for the area of frame parallel view for the depth. If the depth is smaller than 1 millimeter or longer than 5 millimeters, then capture. Final position was optimal, so we release the valve. I'll show you some other cases using the COT technique. 79 female with a perimeter of 83.7, and we chose Evolut with 4 millimeter, 28% oversizing. Long calcium below LCC. As you can see, we slowly implanted the valve in the cuss overlap technique, but you can see in zone 0 in the NCC site. So in this patient, push the delivery system very gently. Then, as you can see, the valve can go inside. So this delivery should be done very gently with feeling the tap sensation in your hand. So after pushing the delivery, it's the pre and post. Pre about 0 to 1 millimeter, about 4 millimeters after. So putting the tension in the system, we slowly release. Finally, the final result is very good. Show another case, 81-year-old male. We chose for 34 millimeter, 26% oversizing. So we pre-ballooned the valve didn't go across the valve. So we implanted in customer outlet view with async. You can see zone 0 or 1 millimeter in the TC side. So we did push delivery very gently. You can see the delivery system. The valve goes into the LV about 3 or 4 millimeters. And you can see the pre, it's about 1 or 2 millimeters. As opposed, it was about 5 millimeters. After checking the valve, we finally released and the position was very optimal. So in our hospital, before COT, the ppm rate was 14.1%. But after customer technique in 2020, it has been reduced to about 4.3%. So its take-home message will be customer overlap technique can be used for minimizing risk of ppm after self-expandable valve. And gentle pushing before final valve release can be an option for optimal position in self-expandable valve. Thank you for your attention.
We had two very, very good presentations, and obviously the last one we will discuss in the absence of both the lecturer and the lecture, but nevertheless, it's well known to us what we're going to be doing. Are there any comments from the panel? I think we don't need to introduce the panel. Dr. Ko, Dr. Lee from Hong Kong, and Dr. Park, Dr. Zhu. Any comments to the previous lectures? First, maybe we talk about the coronary re-access, the excellent presentation, something that's in the mainstream now that we are dealing with the younger patients. We need to make sure that we follow the rules in order to get access to the coronaries.
So I have one question to Professor Ko, and you showed the nice demonstration. How can he re-access after implantation, especially self-expandable valve? And you shows the very interesting phantom model. The tested is how can he access the guiding caster. So my question is about usually, as Didier already shows, even we consider self-expandable valve in the Evolut. We are now trying to high implant based on the cost overlap view, but the phantom model case is, I think, too deep. Is nearly the annulus level is node 4 and 5 level is deeper insertion. If you want to do deeper insertion, usually coronary access is easy. That is shown some anatomic characteristics of self-expandable valve, and so I think some in the real situation it is not the same with the phantom model. Could you comment on that?
Yeah, sure. I think the combination of three conditions. I mean, the high implantation of the valve and a very small space between top of valve and sinus of valsalva, and the long frame height. This combination of three, I think this is the worst scenario for the coronary artery selection. So I think if there is enough space between sinus of valsalva and the valve, we can still pass the wire through the coronary artery system, and then we can perform stenting. However, if there is a small space due to the calcified leaflets or very small SOV size, then it's very difficult. And also, if the coronary ostium position below the annulus level of the top valve, then it's really difficult to engage. So, so in reality, I think the reality is different from the phantom model. So in such case exists, and we have to check if, the aortogram if we have a difficulty to engage the coronary artery system, and then we can find out what is the problem.
Okay. Yeah. Any other
may I add,
comments?
yeah.
Go ahead. Yeah.
So
go ahead,
I just wanted to add to this very important topic. It's true that we are advocating to put the device, to implant the devices very high, just to get a proper sealing and to decrease the pacemaker rate. But this may impede the coronary access afterwards. So first, in our experience, if we have a patient first who is at high risk of coronary obstruction, potentially we're going to put liberally the device lower than we do usually, just to prevent the coronary obstruction at the index procedure. And second, if we think in the future about TAV in TAV, maybe in borderline anatomies, starting with the index procedure with a device that is slightly lower than usually makes sense, just to prevent this skirt exclusion of the sinotubular junction in the future, thinking about the future TAV in TAV for the patient. So the depth is a really important issue, and I thank you for bringing that into the discussion, because there is not one standard procedure. It's all about tailoring the procedure to the patient.
I think this is a very important comment, Didier, particularly when you look at the TAF and TAF situation and you implant the balloon expandable in a self-expandable, and you start out with a lower implant, then the second implant of the balloon expandable valve is easier for coronary access. I think it's a very important comment. Any other
Professor Ko,
remarks?
Professor Ko, can I just ask thank you for showing us the hard rock model. We have been working with the hard rock model as well in Hong Kong. We also try to re-engage the coronary arteries for high implants. What we learned is that it is actually easier if you use a guide wire to guide the guiding catheter all the way to the lower part of the cups, the new cups, so that the guiding catheter, once the wire is get out, is being pulled out, the guiding catheter would most of the time be able to engage into the coronary artery. But my question is, although we actually very much hope to align the commissions, sometimes there must be some commission misalignment. So in case of commission misalignment, when you want to engage the coronary arteries, it is very difficult. We try a number of times. Do you have any tips and tricks when we encounter commission malalignment? What's your tips and tricks to engage the coronary arteries?
Actually, I have to confess that I don't have that much experience, but I think we have to, randomly try, sinus adjacent to the coronary artery ostium, and then, try to pass the wire through the coronary artery system. But I think it is very difficult to visualize the commission post on the angiogram. So I think it's just kind of a blind technique to reach the coronary artery with wire or something else. Yeah.
Yeah, we also approach from the side and then use a guide wire, as you point out, guide wire, try to search for the coronary, and then use maybe extension catheter to make the connection, and then you probably can finish the PCR.
If the sinus valsalva is big enough, then you can also visualize the sinus valsalva and the ostium of the coronary artery system. But if the space is very small, then it'll be very tough.
Yes. Yes. Good.
Michael, if I might add this, if you have a problem due to whatever reason, then I think you should start with an injection into the root. Yes. To make sure where the takeoff is, and then what you should be doing is don't approach the ostium from below. Try it from above, downsize the catheter, half size the guiding catheter, and if you can't engage it, try to do the flying wire, trying to just let the wire fly into the coronary and then follow the usual steps. But you know, that's something that we deal with, and particularly in the United States, where we have structural fellows as opposed to coronary fellows. The structural fellows sometimes don't have the experience and the patience to doing that. So this is an issue of education, but you have to be patient in order to get the wire down. Any other comments on that topic? Didier, any tip or any trick?
So just to add to this very nice discussion, what we've learned from Nico Piazza is how to nicely expose the ostium of the left main. The best projection is the LAO cranial. We know that, but sometimes we don't think about moving to LAO cranial just to be perpendicular to with the ostium of the left main. And the best projection for the right coronary artery is the profile, the 90 degrees projection. So they just keep this in mind. Yeah.
Before we forget,
I have a question to Dr. Ko. Yeah, Dr. Ko. So you talk about the orientation of the cusps in the first TAVR, and if you do the TAVR in TAVR, especially self-expandable inside self-expandable, how can you align the cusp orientation? Because from the beginning, we try to orient the cusp orientation to open the left main side, but sometimes it is not true. We cannot accomplish that kind of orientation. But if you do TAVR in self-expandable, how can you orient the cusp orientation?
You know, I can only use my imagination how to do it, but I don't know exactly. But if the first valve is implanted in the right direction, then I think we try to just follow the first valve. But because of the as the Dr. Didier already told that if we have a self-expandable valve first and then second self-expandable valve, then I think the chance of the coronary obstruction is very high. And I don't know it is the right way to do the redo TAVR in this patient. Maybe the patient needs surgery, or we made other approach. How do you think about this problem, Dr. Grube or Dr. Cheche?
So I think that in the future we will have some new devices just to help us treat our patient in a safer way for TAV in TAV, as for example, the shortcut device. There is a kind of mimicking the basilica procedure, but it's true. I believe that we will have to work on the leaflets, the leaflets of the failing bioprosthesis before putting a second TAVI device inside. So this is going to be very helpful in the future. For the time being, it's really difficult to properly align the commissures of two superimposed stent frames. So I believe more in these leaflet preparation devices.
Yeah, but knowing this, the leaflet modification techniques, be it basilica, shortcut, or whatever devices might come, it's not 100% guarantee that you're going to be successful, because there are two options that is not possible. But Didier, before the session is closed, you stated a very, how can I say, provocative statement that you don't believe in balloon sizing. Go ahead and tell us, why do you say this so firmly?
So this is something that I also like to discuss maybe with the Dr. Su, Dr. Ko, even Dr. Park, because I know that potentially in Asia there is a greater philosophy towards using the balloon sizing, balloon angiography. For myself, I find it useful just to try to understand what is going to be the movement of the leaflets potentially towards the ostium of the coronary arteries, rather than for real sizing. As an example, I've used in the past a 14 millimeter 1/4 millimeter balloon just to and put it across a bicuspid anatomy, and I was able to seal without regurgitation. But no one is going to put such a small device. So for sizing, I'm not sure that this is the appropriate way because it depends on the size of the balloon we use. But for myself, it's more about anticipating the risk of complications. What is your opinion, Dr. Su or Dr. Ko, Dr. Park?
I think I totally agree with DDL, Chiche, and the balloon sizing. At the same time, angiography makes does not reveal everything. So I think the CT measurement is a basic and should be essential to decide what side we should choose for the valve size. So I think just only the balloon sizing is just only accessory for us as well. So I think the DDL is correct. I think this time, yeah.
I also agree with you, Dr. Dill's opinion. We should get information pre-TAVR evaluation, for example, CT or echo. So it's very important thing.
Didier,
what can I say now, Didier? I'm the only one that still believes in it in certain points, and I don't want to be the devil's advocate here, but you know, we've been doing this for many years. I think what you're saying is certainly correct. That you can see how the calcium, the leaflets are moving if you have a question about takeoff of the coronaries. But if you're not having a sophisticated workup of a bicuspid valve the way you described, with careful CT sizing, CT analysis, if you're going across the world and you don't have that, I think balloon sizing is a very efficient way of having an idea how to size, particularly not to oversize. And that's the most important thing. And the reason why I'm still a believer in balloon sizing in certain instances, obviously I cannot compete with the scientific workup the way you described the CT analysis. But based on a general use of sizing difficulties that everybody still has, I think you have a rough idea when you use a balloon in terms of not only how the leaflets are moving, but also what kind of valve you should be using, what size valve you're using. So I wouldn't completely discard. Obviously, he's right because he has the science and he has the analysis behind him. But I think as a practical approach, I think it still makes sense. I don't know how fun, because we are over time now, given the 15 minutes of our missing lecturer and the missing lecture. I think we have to close. Dr. Chair, would you like to adjourn the session?
Yes, thank you very much for the lecturers, and then I'd like to close this session regarding the Evolut system optimization. Thank you for joining us. Thank you, Dr. Grube.
Thank you.
Thank you.
Bye-bye.
Thank you, Eva. Thank you, Didier.